September is National Recovery Month, and to observe the occasion, a group of people in recovery from addictive substances and those who support them organized a march through part of Bennington on Saturday, September 16th, to celebrate breaking free of those dependencies and seeking to make others aware of the help that is available locally to assist others trying to break free from unwanted addictions. Ken Sigsbury, the director of the Turning Point Center of Bennington County, explained what brought the group of about 100 marchers to the corner of School and Pleasant Streets, where they began their march.
Basically, we're walking around the streets of Bennington to symbolize that we're here, we're Turning Point, and we offer recovery. Recovery is very important for people that are suffering because you have to change your lifestyles. You just can't abstain from the use of drugs. You have to change your entire lifestyle. You can't just go back to the same people, places, and things. And we offer some community and unity within the Turning Point environment. And we support any type of recovery process that the individual is interested in. We don't advocate for any specific recovery program. So we're just spreading awareness today. We've got a lot of support here today.
The route took them up Pleasant Street to behind the former middle school, where they turned onto Main Street and down to the First Baptist Church, where they planted a tree before going inside for lunch and to hear a group of speakers. On August 31st in Manchester, a group of 5 women from the North Shire, going by the name of Fed Up, as in fed up about the prevalence of opioid addiction, the shame and silence that often surrounds those affected by the disease, and the inadequate response to date, in their opinion, also joined the marchers. Jerry Witt, one of the group of 5 women from Fed Up, told us why she was there.
We have decided to take advantage of the momentum we've begun building from our rally on August 31st and offer our support to the Turning Point Center. They do remarkable work offering recovery to people in this area, and we want to keep that attitude growing in this community. We want the community to unite, to be concerned and compassionate, and to start helping find solutions to the opiate crisis and to the addictions that are plaguing this country.
Representative Mary Morrissey of Bennington also took part in the march and talked about some legislative initiatives that may be getting underway.
We are tackling on a number of different levels. We've been looking at new protocols with doctors when they're dealing with pain management. We passed legislation this year in regards to fentanyl and the use of. Because right now, a lot of the drugs that folks are getting addicted to are, not only the opiates for pain management, but heroin has taken a significant rise. And so we're trying to look at, and I've always believed that getting someone to treatment and the help they need is far better than incarceration in most cases. We need to be looking to get people back on their feet and as strong as they can, and to help and support them through their recovery journey. I think it is money better spent, and I think the outcomes are better. You can lock everyone up. Some people will feel you can lock everyone up, but that's not going to start chipping away at what the problem is and resolving it.
The opioid epidemic has attracted considerable attention and concern both in Vermont and across the country over the past 5 or so years, although the roots of the present-day crisis go back farther than that. To understand more about how the epidemic of opioid abuse gathered so much momentum, we recently talked with Ken Sigsbury in his office at the Turning Point, as well as with Dr. Trey Dobson of the Southwestern Vermont Medical Center. Sigsbury has recently been appointed to serve on a state council charged with strengthening the state's response to the opiate crisis, and discussed what he saw as the primary needs were.
Basically, especially because of the physical sickness that comes along with opiate addiction from the withdrawal process, is if somebody has decided that they would like to seek help and stop using the opiates and will consent to go to treatment, they need to go to treatment that day or the very next day. They can't wait a week. They cannot wait 2 weeks because their circumstances will change, because the third and the fourth day of opiate withdrawal is so intense. It doesn't just start on the first day. It slowly crawls up to that third and fourth day where it becomes so unbearable that if you have a way of getting those drugs, you're going to get it and the cycle will start all over again. And since you have the drugs, you won't care about going to treatment. So the circular trap starts all over again, and you may have wanted to be in treatment 2 or 3 days ago, but since you have drugs now, you don't care about going to treatment until the time comes back around where you can't afford to buy it or the drugs are not available to you, and then you go back and you want to seek help, and then that cycle starts over again too. 2 to 3 weeks to get into treatment. People with opiate addiction cannot wait that long. It's just not feasible. I would say at least 50 to 60% that are coming in here seeking treatment, don't come back after I've talked to them and said, well, I can get you in somewheres in a week. Now, basically, we only have 2 inpatient treatment centers in in Vermont. That's Serenity House, which is, they have a great program there, and Valley Vista, which is further up north in Bradford. We used to have another facility I'm not sure where it was, but I believe it was a little further up north, called Maple Leaf. Maple Leaf had 41 beds. They closed Maple Leaf like 6 or 8 months ago, and there was no backup plan. Maple Leaf closed down, and all these people that were seeking treatment, their wait time went out further. Now there are outpatient options too, where you can get medically assisted treatment, which means you go and you get on either a methadone or Suboxone program, and a Vivitrol program, and then that's another avenue to go for the person that's struggling with opiate addiction. But still, you can probably get on one of the outpatient programs in 1 to 2 weeks as well. So we still have that variance of time where that 3rd and 4th day are so critical for those individuals to be in treatment, that they're so sick that they can't do anything about it, so they have to seek more heroin or more opiates, in whatever form it may be. But I mean, it's basically opium, which has been around for years, like forever. But so that's the biggest concern. My thing is that if someone's ready to go to treatment, they have to go that day or the very next day. We have to show a priority. I would like to see, because the 2 facilities that we have in Vermont, I would like to see them get more funding so they can expand, because they have wonderful programs. Especially, Serenity, I go up maybe once a month to Serenity House, and I do a presentation there. So we talk about recovery, because recovery is lifelong. Treatment is for a certain period of time. I call that the pause period, where people can go someplace and take it easy and get some help and just become physically well. But what we have to still do in recovery is deal with the addiction itself, and people living a normal life and moving forward, because abstinence is such a small part of recovery. We actually want to grow and become the best version of ourselves possible, and that is the backfill. We replace that. Drugs occupied so much space in our lives before. If we can focus on being that person that we'd like to be, that's the backfill for that. And I think that's the solution. Treatment is for a period of time. Recovery is lifelong.
Dr. Trey Dobson explained his take on how we got here. How did the opioid epidemic get started, and the adjustments that have been made within the medical community in recent years to try and turn things around?
And I just want the viewers to understand that that I'm a physician. I'm an emergency physician, so I deal a lot with analgesia, pain medications, but I'm also not an expert on this. So my perspective is based on my experience. And I'll start by saying my experience is 12 years, and this problem began a little before that. You're talking mid-90s to the early 2000s. And I think people have seen a lot of media reports on them, and most of which I support. So a lot of regulatory agencies came out and were asking physicians, hospital systems, to really focus on pain as what they call the 5th vital sign, right? You have your temperature, your blood pressure, your respiratory rate, heart rate. and then your pain scale. And when opioids came out, and they were pushed by pharmaceutical companies as good treatment for pain, initially it was for diseases such as cancer. They cause tremendous pain, particularly from bones, when you get cancer in your bones and other parts of your body. And we saw they worked really well. Fast forward a couple of years, and they started being prescribed for acute pain. Patients coming in with some severe acute pain, and they worked well for that. Then they started being prescribed, because they were more readily available, for more chronic pain. You mentioned this earlier, back pain. That was a very typical one. I think most everyone, after they've gotten past the age of 40, has had some type of back pain, and as you get older, it gets worse. And so opioids would be prescribed, intended to be for a short term. They keep getting refilled because they seem to be working. And the data was not out there to show the addiction properties. At least it wasn't widespread. I don't know whether or not it was suppressed. It certainly was not suppressed by the medical community. So it took a while. Unfortunately, prescription rates for opioids for this chronic type pain shot up tremendously. Again, just emphasizing certain cancer pains, acute pain. If someone comes into our emergency department with an acute fracture or really bad wound, giving them opioids right then does not lead to addiction and certainly helps their suffering. It's the use of them over a 2 to 3 month time period that really sets up people for the potential for addiction. And I think most of your viewers know addiction is a difficult science. Most people do not get addicted to things, but a way high percentage of patients were getting addicted to these painkillers, more than certainly anyone anticipated or wanted. Most any physician or a healthcare provider goes into their field because they want to end suffering. They certainly don't want to cause suffering, and they're not indifferent to it. That's why they went into it in the first place. So then if you look at 10 to 12 years ago, and again, my perspective as an emergency department physician, we started seeing that there would be a group of people that would be coming back to the emergency department or back to their primary care provider, insistent upon the medication when we knew it was time for them to be stopped. That's the first real red flags, at least from my perspective. Now, I'm sure if you talk to others from different parts of the country where epidemics may have started earlier, they may have seen things earlier. So we put in place, for example, here and many places around the country, starting 5 to 8 years ago, we started putting hard guidelines in, and physicians not only were not opposed, the physicians were the ones themselves that wrote these guidelines. This is before the state started creating laws, which we can talk about, even before national groups started writing guidelines. So I think physicians have do a pretty good job of detecting something going on before it needs to be legislated. That being said, I definitely support legislation on controlling opioid use.
What's the standard regimen or protocol that happens with a patient who's been treated for a back injury, let's say, or some kind of chronic pain situation? They leave the hospital. Do they leave the hospital with some prescription opioids in their pockets and a prescription for more, or are they kind of like, do they given any kind of like guidance on or program on how to monitor the use?
So it's a great question, because the answer I'm going to give you today is far different from what I would have given you even 2 to 3 years ago. And that is far different from what you'd have received from me 5 or 6 years ago. So the emergency department, for example, about 5 years ago, we put opioid prescribing guidelines in place. We also, we had listed out certain illnesses or certain injuries that would not benefit from opioids, and therefore we were not prescribing. We also started making changes in our electronic medical record that would limit the number that we could prescribe. This is, again, before the state and before the CDC even jumped in with guidelines. So today, if you had someone that came in with severe acute pain that needed relief in our emergency department, or for that matter in an office setting, they would get the appropriate analgesia right then that they needed. But as far as prescription use, it's significantly decreased. Refills are extremely rare, so we don't give refills. And we do know that the data does not support addiction in very short-term prescriptions of opioids, and that the opioids work in certain illnesses and certain trauma. So we don't want to take away the ability to control someone's suffering. I mean, if my child comes in or my wife comes in severe pain, we know there's negative ramifications from that can last a really long time. But as far as someone coming in with back pain that's typical, maybe not from a bad traumatic event, they don't even get opioids in most places anymore. Most physicians do not prescribe those. We have the discussion with the patient. We have education materials if they are going to receive a prescription, and we limit the number of days significantly. In our hospital system, for example, when someone has surgery, and this is in a lot of hospitals, so SVMC has been definitely on the forefront, but many other places do this. The prescriptions used to be written at the time of the surgery, and you would have a certain amount of prescription written because that was kind of a typical amount. But now we don't do that. At discharge, we assess their pain. We see how they are doing. And we've found that most of the patients do not need the analgesia. So it's just not even written. They don't even get it filled. And there's a couple of good studies, you can look these up, out of Dartmouth-Hitchcock and then also UVM, here in New England, looking at post-orthopedic or post-general surgery patients and the percentage that really needed opioid analgesia prescribed. And it's smaller than what was anticipated. So we've cut down significantly. And I think are you aware of the Vermont legislated opioid rules? And many states have these now. So starting back in about 2014, and I may have that date off a little bit, the state passed legislation that prohibited prescribing of, or excuse me, I should say limited prescribing of opioids, particularly for chronic conditions. And then July 1st, 2017, there were some changes ahead of time, but July 1st, 2017, the rules were definitely escalated. So there's a lot of hoops to jump through, really to validate if someone needs a prescription for opioids. And you can look those rules up, but we have to first look the patient up on the computer database and see whether or not they are getting opioids from another provider, because that's where people can have too much prescribed. We have to look and see when the last time they had prescription filled. We have to provide them education on addiction and services to help them through that. We have to provide them with education on the dangers of the opioids. So those barriers in themselves significantly reduce, although we'll say physicians have been on top of this for just at least the last, you'll look and see, it's probably the last 2 years, so we've cut down significantly. So there's a lot of media attention on prescribing opioids, and there should be. Again, I want to reassure people, a vast majority of physicians are on top of this, but that doesn't mean the problem's not here. It is here. There's still problems. There's still ways we can help with this. But what you've seen is a transformation in the 90s from injectable opioids to oral opioids. I was just talking with a couple of DEA agents a month ago out of the Boston area. They're kind of in charge of the New England area. And when they're doing raids now, and when they look at post-mortem autopsy reports, a vast majority are no longer prescription drugs. They may have gotten into the illicit substances because of prescriptions, which we've talked about, but the vast majority is actually fentanyl. Fentanyl is a derivative of morphine, just like heroin is a derivative of morphine. It's incredibly powerful, much more powerful. In fact, 7 grains, so like 7 salt grains, 7 grains of fentanyl is potentially a lethal dose. And these medications are coming out of 2 places, China and Mexico, where it's, where illegal activity occurs. So patients on the street that are getting these, I shouldn't say patients now because these are no longer patients, these are people on the street that are getting these medications, they all think they're getting, or many think they're getting heroin, but when they test it in the lab over the past 12 months in New England, especially the Massachusetts, New Hampshire area, it's almost all fentanyl, even though they think it's heroin. And the problem with that is these small amounts can lead to death. So when you mix them and you make a pill form, so again, now no longer needed to inject, you can just take a pill. You lose that stigma of injection. The what I call the purity of the pill is very hard to predict, because when you mix up the fentanyl with your filler, which can be anything, any type of powder. It's hard to mix it in a way that assures you, I'll make this up, 5 grains per pill. So one pill may have 2 grains, the next pill may have 20. And that's where you're hearing about all these overdoses where maybe 5 or 6 people in one town over one night period have an overdose. It comes from getting a batch where the mixing wasn't thorough. What I do want to say is that the prescribing habits of physicians, nurse practitioners, and physician assistants, those who prescribe, has significantly improved with the vast majority of the physicians. I mean, here and in many places, we monitor it. And someone is an outlier, you go to them right away. Typically what you find out is it's an oncologist, right? So that's okay, or a palliative care physician. But if there's a primary care physician, sports medicine, orthopedist, general surgeon, emergency physician, if they're outside of their peer group, then we go to them right away. One more thing I was going to say. SVMC and multiple other locations in the country are putting up these boxes where you can dispense your medications. You may have heard of that. We tried to do this 5 or 6 years ago. Again, just 5 years ago was a different era, and we ran into all kind of problems with how you're going to dispose the drugs, and it got to be problematic. But our administration has supported us in this. The physicians have been the lead, and they've said it doesn't matter what it takes. We need a spot so that people can bring back their medications, whether they're opioids or not, just to get them away from the medicine cabinets. If you need them, great. If you're done with them, let's get rid of them.
For the GNet TV News Project, I'm Andrew McKeever.